Dr. Bunn, it's great to see you again. I know how busy you are, so we have limited time. I just want to mention that you wear multiple hats. One is the executive director of the International Association for the Study of Lung Cancer, and also you are James Dudley Professor at the University of Colorado, and truly one of the world's leading key opinion leaders in the area of lung cancer.
I don't know about the latter, but the former two
It's
are
the
absolutely true.
Absolutely, it's
and
the
I'm
truth.
happy to be here.
So, you know, I am amazed at the volume of data and hope that's blossoming in the area for lung cancer. But I'm going to turn right to you to talk to us about what you think right now at this ASCO meeting, 2010. What do you think the real hot story is?
So, lung cancer is the leading cause of cancer death in men and women in the U.S. and will remain so for many years. And unfortunately, most people present with advanced metastatic disease for which the outcome in the past has been extremely poor. And the standard for many years has been to give chemotherapy intravenously with lots of side effects. And it's had a small impact on survival, but not very much. And in the past, we never biopsied a patient's tumor to see what was driving the patient's tumor. And we've now learned that in many lung cancers, we can identify what's driving the cancer. And in most of these that we've identified so far, it's a activation of an oncogene, a gene that causes cancer, and single ones. So the first one was identified was a gene called the epidermal growth factor receptor. And there are pills that target that. In 2004, it was identified that there are mutations in this gene and that these pills are better than chemotherapy for patients that have that molecular abnormality. In 2007, a new molecular gene was described, the so-called EML4 ALK fusion gene, 2007. And at this meeting, the first 81 patients that received that drug, 77 of whom responded, and essentially all of whom are still on drug after a year. So really, 3 years after the discovery of a gene, we have a treatment which is going to be way better. Now, unfortunately, only 4% of all patients with lung cancer have this gene. In certain categories, it's higher. But it shows that the area of personalized medicine is here. It shows for lung cancer patients, if you get your tumor tested, it may be that you have a pill that will markedly extend your life with good quality.
So it's really all about being able to look at one's individual molecular characteristics and then design a therapy that targets.
Correct. There's more examples here this time of just taking the whole population of lung cancer, which is actually heterogeneous, so there's many types of lung cancer within there, and giving a drug unselected to all those patients and getting a negative result, when frequently there's a subgroup that's in there that you miss when you do that. And now we biopsy the tumor, we look at the molecular characteristics, we give a treatment specific for the patient.
Well, tissue study isn't just about looking at it under a microscope anymore. Now it's
Correct.
Molecular pathology.
Correct. The tissue is the tissue issue. The tissue is the issue has new meaning.
Right.
It used to be you had to make a diagnosis of cancer by looking at it under the microscope. Now you not only have to do that, but then you need to know the molecular characteristics of the tumor.
Okay, so we've talked about this sort of, genetic issue within your specimen. What about the hope for the cancer, the vaccines that are immunology, where you take the piece of the tissue in the operating room and you look at that again to see if you express a certain protein? You think that there's going to be...
So, to a certain extent, it's the same principle. Most vaccines are directed toward a single antigen, a protein that's on the cell surface of a cancer cell. There are 3, maybe more, but there are at least 3 vaccines that are in phase 3 trial in lung cancer. And at this meeting, a smaller trial with great promise, which is a drug called ipilimumab, which blocks part of the immune system that's inhibiting the rest of the immune system from attacking the cancer. And so there's a promising study with this drug ipilimumab. At the moment, there are no vaccines approved, but most vaccines, also you look to see if the tumor has the target, and that's the people you go after.
Lung cancer is an interdisciplinary or multidisciplinary disease, so you know you've got the pulmonologist, you have the surgeon, you have the medical oncologist, possibly the radiation oncologist, but suddenly I think that there's a really big role happening for the pathologist and the molecular pathologist.
Tremendous. And some community pathologists, we need to provide education because they're somewhat unaware of this. And there's another issue there, and that is years ago when you were a patient and you went from one place to another, the hospital wouldn't release your x-rays. Okay? And after a few lawsuits, it was proven that the patient, not the hospital, owns the x-ray. Well, we have that issue in pathology. Hospitals get a tissue block from a patient's biopsy, and a hospital thinks they own that tissue block. And they're often reluctant to release it to somebody else to do the molecular testing. In my opinion, it wouldn't be so bad if we had a lawsuit to prove that the patient owns the block, not the Department
I
of
will
Pathology.
hold that banner. I could talk to you for hours, and while you're going to have to leave us now, I'd like to make a date, we don't know the date yet, that we're going to do this again.
Okay.
Thank you.